views and opinions expressed in this program are those of the participants and do not necessarily reflect the views of Bronxnet or the program underwriters.
Welcome to Public Health America, a 30-minute program on Bronxnet where we talk with national experts to promote health and social justice. I'm your host, Dr. William Latimer. We begin by focusing on a current health topic from the COVID pandemic to cardiovascular disease. Our goal is to provide you with not only the best science, but practical tips to live a healthier life. On Public Health America, we also celebrate what studies have long documented, namely the unparalleled value of a college education by setting the stage to pursue a career of your choice, increase lifetime earnings and opportunity, and champion the ability to engage in civil debate. But for many, finding a path to college is neither clear nor certain. What if you're a high school student with supportive parents, but feel daunted by the prospect of being the first in your family to attend college? What if you're a single mother or father and want to attend college, but have no childcare? On Public Health America, our expert will also talk about decisions they made and support they received that helped them beat the odds. By sharing one or two life lessons, their stories may provide you with the inspiration and method to realize your dreams. This is Public Health America. Welcome to Public Health America. I'm your host, Dr. William Latimer. It's my pleasure to welcome Dr. Typhanye Dyer to the program, Associate Professor in Epidemiology and Biostatistics at University of Maryland, College Park. Typhanye, welcome.
Thank you so much, Bill, for having me.
My pleasure, my pleasure. So I know you've been doing some cutting edge work looking at stigma in vulnerable populations. Set the table for us. What populations are you working with, and what are you looking at in terms of stigma?
Okay, thank you so much. So the populations that I'm most focused in would be considered vulnerable populations, right, or marginalized populations. Some people like to use the term hard to reach, but that's sort of being challenged a little bit just with respect to how we engage communities. And some people aren't hard to reach. They just either don't want to be reached, or they are, tired of being researched on sort of all the time. And so most of the work that I do is with sexual and gender minorities, particularly men who have sex with men, and more specifically, Black men who have sex with men, as well as Black transgender women. And some of the work that I do is with cisgender Black women who are living with HIV, and looking at intersectional stigma. So stigma along the lines of not only having HIV, but other social positions for which they might be discriminated against as well. So that would be age, race, ethnicity, and then of course being a woman, and then living with HIV and any other comorbid conditions that they might have. So those are the populations that I typically work with as it relates to addressing stigma, or trying to understand stigma and how it impacts engagement in the care continuum.
So that's very helpful in terms of understanding the populations. Is it fair to ask the question, define stigma? It's a word that everyone uses, but it just seems to me that sort of having clarity in the definition might matter. What can you tell us about that?
Absolutely. I'm glad that you asked that as well, because I think a lot of times people get stigma confused with things, right? So it's stigma, I would say, is when a person is labeled or stereotyped by their, in this case, HIV, by their illness. They're no longer seen as an individual, but as part of a stereotyped group, a group that is oftentimes misunderstood by the majority of society. And so there are negative attitudes and beliefs towards this particular group that create prejudice, which leads to negative actions and discrimination, right? And so I think when we talk about stigma, we also have to talk about the isms. So we have to talk about racism. We have to talk about sexism. We have to talk about xenophobia. We have to talk about homophobia. And we do have to talk about discrimination. And so what I'm usually talking about is a social stigma, a stigma that's related to one's social positions. And being a member of those groups, right, in this case, I would say being an older Black woman living with HIV, they intersect with one another, creating an intersectional sort of level of stigma that we need to, I think, address. And so, again, I think people confuse stigma with discrimination, but discrimination is definitely one of the major facets of someone feeling stigmatized.
Got it. That's helpful. So as I think about the populations that you're working with, and then the nature of stigma, that there's so many potentially important directions that one might go in terms of either intervention or prevention or work or research. So give us a little bit of a rundown of what is some of the major foci of the work you're doing.
Great. That's an excellent question. Thank you so much. Well, I think it needs to be multi-level, right? I don't think that we are going to get really far with engaging people, in this case, people who are either living with HIV or at risk for HIV. Even saying someone is at risk is oftentimes stigmatizing. So I think a lot of times you have to think about our health communication. But I would probably start with some formative research. I'm an epidemiologist. And so at times we don't, think about qualitative research. So I would start with focus groups, engage the community, find out where they are with respect to potentially dealing with stigma. Most people have in some capacity. And then thinking about what their ideal intervention would look like. What are the different levels of focus that we should have as researchers or as public health practitioners in general? So I often think about my work is in syndemics, and those are intersecting synergistic things that people deal with. But what we do oftentimes is we have a siloed approach. We'll deal with your infectious disease, we'll deal with your gynecological thing, we'll deal with your mental health, your behavioral health, your something else. And I think that there needs to be an integration of the work that people do so that we can create a whole person. So wraparound care. And I would start with the people, and then also start with the organizations that are on the ground that are already doing the work. Like Heart to Hand, which is here in Prince George's County. They do wraparound services for people in Prince George's County related to HIV, health and wellness. Great.
So let me ask this. So I was listening, this is going to be the second time I've plugged NPR on my show. They should be sending me checks. I was listening to an NPR show. It was very interesting. And the gentleman had written a book, and he was talking about the civil rights movement versus the women's movement and suffrage versus same sex marriage. And he was making the point that the speed with which things changed from the 90s to today was in effect much faster than things changed in the civil rights movement and the women's movement. Now, I'm leading up to a question, and that's this. Are there still, and I'll make one more point. A point was made that 30 years ago, if you did a random survey of how many people knew people themselves directly that were in a same-sex relationship, that it would be less than 1%, and today it would be 100%. So that's just an emblematic of the enormous change that's happened in 3 decades. Obviously, there's much more work to be done. My question is this: is it difficult to reach the vulnerable or the populations that you want to work with, or is it easier, or is it like, where do we stand on that? Because if you can't get to them, that would be obviously an important barrier. Where do we stand on that?
That's an excellent question. I just taught a class on this. That's interesting. And it's how to sample hard to reach populations. And again, thinking about hard to reach, right? So again, thinking about people who are kind of in the shadows. Because of the stigmatized nature of what we're talking about, which is HIV in this case, and we can talk about any other outcome that for whatever reason has, and we know what HIV, what it was, and it's the fact that it was called the gay cancer from the outset, which is problematic, and it just cannot live itself down from being termed that from the outset. But again, I think we start with the community. So what I talked about was finding ways to engage a community that, because of the stigmatized nature of what we're talking about, sometimes don't want to be found. I mean, it's one thing to tell. I mean, how do you tell women that they're eligible for PrEP? even the guidelines for PrEP are stigmatizing. You have to do this, this, and this. Your partner has to be this, this, and that. And there are women who are like, well, no, I don't think I'm eligible then in those cases. And so we have to also think about the different dimensions of stigma, right? So for some people, they are experienced. They've actually experienced discrimination in the healthcare setting. They then internalize and anticipate that this is something that's going to happen, right? And so they don't want to go seek the care that might be available to them. So we need to start with the people and then sort of build it out, right? But it's hard to find people. I would want to have focus groups where people bring in other people that are like themselves, be that gender, race, ethnicity, age, HIV status, and really get some conversation going around where we can go as public health practitioners to reduce the effects of stigma and actually have people understand their own feelings around internalizing this stigma and this discrimination that have been put on them, and how they can become resilient is tough because it's like just getting by, but I think thriving in a way that they can be healthy.
Sure. We've got about a minute left in this first part of the segment. So clearly we need data, we need information collected, we need to get folks at the table, we need to understand their lived experiences today to set the table for next steps.
Yeah.
This is a broad question, but to what extent do you see medium or long term the need to sort of interface with services that they would receive, whether healthcare or otherwise, to also educate providers?
Absolutely. I think immediate, short term and long term. I mean, maybe long term, or medium term, I guess I could say. Thinking about wraparound and comprehensive services. Is there a social worker on staff? Is there someone that you can talk to about your mental health on staff? Addressing provider bias is one of the sort of issues that we have to contend with as well. We're talking about formative research, qualitative, but as an epidemiologist, and you know this, as a psychologist, we have scales that we could use as well. The Everyday Discrimination Scale by Williams. We can talk about the HIV stigma scale. Really, we can collect some data, but I think we also want to develop some sort of services where we can do provider interventions or think about systems level interventions, because people are trained to do what they do and they don't know anything else. And actually, if you tell your gynecologist that you're seeing an HIV provider or whatever, they're going to, there's some discriminatory action that's going to happen there. They stigmatize other health professionals, right? Oh, they don't know. They're not sure. Oh, that's your mental health. That's not this, right? But it's the whole person. And so I think some of it is with training of our healthcare professionals as well, some interdisciplinary training or practice that we actually need to implement at the educational level as well.
Great. We're going to take a quick break. When we return, Dr. Typhanye Dyer will tell us a little bit more about some of the work that she's doing. This is Public Health America. I'm Dr. William Latimer. Welcome back to Public Health America. I'm your host, Dr. William Latimer. We're here today with Dr. Typhanye Dyer, Associate Professor of Epidemiology and Biostatistics at University of Maryland, College Park. So Typhanye, I know, a topic certainly on many people's minds is variations in vaccine uptake by population, and certainly with the Delta variant and with very significant variations of infection rate by state that clearly seems to be linked to vaccine uptake rates and mask use or not, is all in the mix. So tell us a little bit about the work you're doing and your thoughts on this topic.
Thank you, Bill, for that. So I'm an infectious disease epidemiologist, and my job is really as a social and behavioral epidemiologist. Although it's infectious disease, it's less clinical. So what I really try to do is get a better understanding of people's behaviors, and what are some of the social factors that influence people's behaviors, right? And so what I've talked about with my classmates, my colleagues, etc., are what are some of the things that are preventing people from still getting vaccinated. We had the segment of the population that were just kind of waiting to see what would happen. Like we I just want to see, like, do people get sick? What's part of the population that actually has been vaccinated? What are the side effects? There were people that were waiting. And I think those people have probably teeter toward the side of, okay, I'm going to get vaccinated. And then we've got people who just are not going to be vaccinated. They don't trust the medical healthcare system. They don't trust research. They don't trust scientists. They don't trust a lot of things. Those are the people that we really, really need to focus on in terms of what can we do. I mean, we've offered incentives. We'll give you $100 if you come in and get vaccinated. Nope. So what are some things that we can do as public health professionals to really convince people that it's safer to be vaccinated than it is to not be vaccinated, for yourself and others?
And it seems to me, and I read the newspapers. I listen to public radio, etc. I talk to colleagues that know a lot more than I do. It seems to me like an incredibly heterogeneous group that don't want to be vaccinated, meaning it's not just one type of person. And it seems to me that it's plausible that on one hand, intervening with any population that's not interested in being vaccinated might require the same intervention to get them to consider it. And then it's also conceivable to me that it might take a very different approach. Is there any, I have yet to see a discussion or a debate or a literature on how to reach, and I'll just pull this out of a hat, rural, low-income families versus inner city people of color, both of which may have distrust of the medical industry for exceedingly different reasons. Is there any literature or any discussion on how we reach different populations to get them vaccinated?
I haven't seen much literature in that area as well. I mean, either. But I do think that that's where the discussion needs to head, though, right? Because you're correct in that it's a heterogeneous group of people who refuse to get vaccinated, and it's not a one size fits all. Obviously they're heterogeneous, but I think even our approach to discuss with them vaccines, what they do, what they don't do. See, there are people who are like, I told you, didn't work, because there are breakthrough infections, or there are people who are vaccinated who still are getting it. And what needs to be understood is that while that might be the case, not only are you less likely to be put on a ventilator and potentially die, but your symptoms are actually lessened significantly. The tricky part with that is that you could have it, not know it, and potentially spread it to people. And so I think there's still this, people want things to be perfect, and there is no perfect solution to this. It requires a lot of things, like you said, a mask, the vaccine, social distancing, and doing all the public health measures that we know we should do, washing our hands for 20 seconds, et cetera, et cetera. But I think, it's almost like peer group peer navigation that we talk about in public health, that it probably requires someone from their own community who looks like them and potentially had the same ideologies as they did or do, to discuss their reasons for getting vaccinated. And a lot of times we've seen this happen. It was the death or the illness of a family member and a loved one that finally got someone to go and say, I'm going to do this. And then it's too late.
That makes a lot of sense. I mean, certainly what resonates with me is, and I suppose it's just common sense, like your grandparents could have told you this, but find people that can relate to those folks that are uncomfortable with vaccination or outrightly against it, and do the outreach that way as best as one can. Let me ask you this. Let's think about MMR vaccine, right? I mean, I don't know the history and I don't know how long, but I do know this: if you don't have your MMR, you can't go to public school. It's not a discussion. It's not a debate about civil liberties. It's, we don't want children or people spreading measles, mumps, etc. And so, take this, and then you can come to school. And if not, that's fine. That's your right. That's your choice, and you can homeschool and all the best. So, last I checked, of the roughly 4,000 to 4,500 higher education institutions in the United States of America, that somewhere around 800 to 1,000 are requiring COVID vaccine in order to go to college. So that's a big number, but certainly not a majority yet. What direction do you see this going? Is it going to be a 20-year debate, or are we getting? Do you see a point on the horizon where basically this vaccine becomes a requirement like MMR is?
I actually see that it would eventually be a requirement like MMR. I think the tricky part is the mutant strains or the variants. I think is so it feels like we're playing catch up. As soon as we feel like we've gotten some leverage, then here's another variant of the virus. But I think it's going to be definitely required. I know people think that it's socialism and all of this and that and the other thing, but again, we're thinking about the health of the population. And it always gets me when someone says, "Oh, it's my body, my choice." And it's like, but it's not just your body, it's also my body when I'm sitting next to you on the bench waiting for the bus or whatever we're doing, right? And so it isn't just your body, right? It's an infectious communicable disease is what it is. It's infectious and it's communicable, right? And so that's why we wear the mask, et cetera. And I fully think that it's going to be mandatory. And I know people, they don't like that, right? We're doing it here at Maryland. It's being fully vaccinated is required by all faculty, staff, and students.
Yep.
Period.
Yep.
Yeah.
So Maryland's already taken the dive. I know that I believe it's accurate to say that there are a number of institutions in New York State that have required it. The alternative at the moment that I'm aware of is, proof of vaccination or frequent testing as an alternative. But, I'm inclined to agree. I think it is a matter of time before this becomes a kind of industry standard. But, there's a lot of debate along the way, and rightfully so. What do you see as the key elements that an epidemiologist is trying to track when scientifically providing support to utilizing vaccine to the general public? So what's the database side of this that epidemiology contributes?
Well, that's very interesting. So what we contribute is, it's so great. I keep saying like I teach this in class because obviously I teach Epi. I teach Epi 1. So one of the so what we do or what we contribute is the ability to keep track, I'll say, of the epidemic, right? That means counting cases, doing contact tracing, doing outbreak investigations. If there's a cluster, what's that, like 3 or more? of cases in a classroom, in a particular setting. So that's our job, right? And to also provide surveillance so that we can keep track of the counts and keep track of where there might be these clusters and where we need to focus our energy, be that a focused any policy, practice. Is there a certain community where there needs to be really, foot soldiers, people on the ground trying to get people in to become vaccinated if it's really, really, really low prevalence of people in the community and the rates of COVID are really high. And so I think that's our job as epidemiologists. And again, from a clinical perspective, understanding the mechanisms and the ways that that virus actually works inside of your body, what it really does and what it isn't doing that people think it's doing, what we're doing when we say messenger RNA that people think it's doing and it's not doing. It's a messenger. It's like someone dropping off a piece of mail in your mailbox and they keep moving, right? You bring the mail into your house, you open the mail, et cetera, right? And so it's not changing your DNA. It's doing what it's doing so that it prevents severe or moderate symptoms should you be exposed to the virus.
So we've got just about 45 seconds left. Let me ask another kind of challenging question. Rightfully, there's been a lot of press lately on much higher rates of transmission among children and young children in schools and other locations, particularly where vaccine uptake is low. Any thoughts about that, what we need to be doing, or what the science is suggesting we do?
It's really tough because the babies cannot get vaccinated, right? And so I know that's a soft spot, for you as well. But I think about my grandson, right? So what I tell people is the children need to wear their masks. I know it's tough because it is true. It does affect learning. It's hard to read lips if the mask is on or no, it's just hard. And the kids are stressed as well. But I think as adults, we need to do our duty to reduce risk for our children and reduce the likelihood that they're going to be on a ventilator or that they die or something or just get really, really sick. Nobody wants that for their babies. And so we have to wear the mask. And I think getting vaccinated is the way to reduce transmission risk for our younger population who really don't have a say in this. They don't have a say in whether or not they can get a vaccine. So as their parents, as their caregivers, as their guardians, as their aunts, uncles, cousins, whatever we are to them, I think we do our due diligence and do what we can to reduce their risk because they are the most vulnerable population, right? And so I think we have to do what we have to do.
And with that, I mean, I think, let's all hope that vaccine is available to infants and children soon. And I know people are working on that. So I want to thank Dr. Typhanye Dyer for joining us on Public Health America. I want to thank our viewers for tuning in. I'm your host, Dr. William Latimer. We'll see you next time on Public Health America. Take care.
Thank you, Bill. Thank you.